Today I'm going to talk about chest x-rays. I read about 150 to 300 chest x-rays a day. You probably see a lot of chest x-rays per day also. I'd like to share with you my approach. I do the same thing for every one of those chest x-rays all day long. And no matter how easy it is or how complicated it is, it's important that I do things in a methodical way so I don't miss anything. And a second set of eyes like yours is always helpful, right? You know the patient, so you know exactly where to look. So you have such an opportunity to find things that I may not be able to see. I speak for Jen and Sam and Boyder in pulmonary fibrosis. So you can imagine how excited Wilhelm Conrad Röntgen was when he discovered the chest x-ray. And I have the earliest article I could find on that experience. Let's see, I'd like to share this with everybody. So what date is this article?
Oh, there we go. February 15th, 1896.
February 15th, 1896. And look at how they write there. It's delicious at this time. In the course of some experiments on a Röntgen ray, I have hit upon a series of such extraordinary effects that I hasten to place them on record without furder loss of time, believing them to be of the utmost importance. Right? We don't write like that anymore. Right? So he writes this article saying he took a picture of this key and this coin. He was very excited about it. And then this article comes out not too long after, just for verification of the dates.
May 30th, 1896.
So 3 months later, a young person, 22, is riding his horse. The horse falls on top of him and he gets unconscious. They think he has epidural hematoma. And then he also knows that his elbow is swollen. And so they use that tool to take this picture and show that he has an elbow dislocation. How long would that process take in current day to develop an x-ray machine and use it on patients, right? It would take at least, you got to study on mice for 5 years. But in 3 months, they thought, and I just think that's such an amazing that they thought, went from taking a picture of keys to taking a picture of an elbow dislocation was amazing that they were able to do that. So I'm humbled by their great idea. Now, when we look at a chest x-ray, we see these all day long. This is a beautiful chest x-ray exam because we can see it so clearly. This is the approach I take when looking at chest x-rays. I look at the line, so I want to look at anything that the patient wasn't born with first. I look at the bones. I'm going to show you how to do each of these. I look at the heart, the costophrenic angles, the lungs, the abdomen, and trachea in that exact order. And so I ask my students, I'm always trying to engage them, to come up with a mnemonic that I could share with people that has these letters in it, right? Those are the really hard letters to make a mnemonic, right? They don't look good. Is there a vowel? There's one vowel down here. And the student, he was a challenging student. He was always giving me a hard time, but he came in the morning really excited because he had come up with a mnemonic for these letters. And the mnemonic is, let's be honest, Cheerios lack actual taste. That was what he came up with, and he was really excited about it. And I share that now all the time. So let's use that as the mnemonic we use to look at a chest x-ray. So when you look at this chest x-ray, what does the patient have that they weren't born with? They have a catheter, right? They have this right IJ catheter. And we can call it an IJ catheter because this part is not going into the clavicle. So in subclavian, if it goes underneath the clavicle, and if it doesn't go underneath the clavicle, it's an IJ. All right-sided catheters must stay on the right side. All left-sided catheters must go to the right side. When they don't, alarm should go off. You need to make sure that this patient doesn't have a catheter in their artery. I've watched 2 patients in my career exsanguinate from having a catheter in an artery that was destroyed, not knowing that it was an artery, and we couldn't stop the bleeding. So all right-sided catheters need to stay on the right, all left-sided catheters need to go to the right. If they're not doing that, it may be that they're in a vein, but you have to go check a blood gas to make sure that they are venous. So this patient, maybe we should turn the lights down, we think, maybe. This patient has a right-sided catheter. Look at the endotracheal tube. How far do we want an endotracheal tube to be down? Everyone says 2.5 centimeters from the carina. But these films are magnified, and it's hard to measure. And also, we don't know the position of the patient's head. So I don't get excited about an endotracheal tube unless it's above the clavicles. This one is going right to here, or touching the carina. Now, how do we know what happens to the patient's endotracheal tube when they've been there? That's intuitive, right? But somebody must have done a research study. They found, as goes the nose, so goes the hose, okay? So you picture them positioning people's heads, taking x-rays, I don't know. But somehow they proved that the endotracheal tube moves with the head. And so I don't get too excited about keeping it exactly 2.5 centimeters because I don't know where the head is in the patient. Here we see a feeding tube, not so well that it's projecting, but we want feeding tubes to go below the diaphragm. They really can't go too deep. Swan-Ganz catheters, this is the right IJ, not a subclavian. Swan-Ganz catheter is going into the right atrium, the right ventricle, the main pulmonary artery, the right pulmonary artery. This is too deep. It really shouldn't project beyond the mediastinum. So if I see this, I'm going to call you and say, ask you to retract it slightly. At least radiographically, it looks too deep. Here we have a tracheostomy tube, sternotomy wires, a left IJ catheter. This patient has pulmonary edema. Chest tubes. Where are you going to put a chest tube in a patient who is lying in the bed and has pleural effusion? Where do you want to put it? Where's the money? You're going to put it posteriorly, right? If the patient's upright and walking and they have a pleural effusion, where would you want to put the chest tube? In the inferior aspect. And reverse for pneumothorax. So if someone is supine and they have a pneumothorax, you're going to want to put it anteriorly, and if they're walking around, have a pneumothorax superiorly. With the chest tube, you see this line that's radiopaque. It has a discontinuity, and then it becomes continuous again. This discontinuity represents the most proximal side hole. So the only thing that we can do to say that a chest tube is in good position is that this discontinuity projects over the hemithorax. If it projects outside the hemithorax, then we know that the patient is going to have an airway. Also, if we have a persistent pneumothorax and patient with a chest tube, we know that it's not in the correct position. This is definitely not in the correct position, right? You can see the feeding tube going into the right lower bronchus. So we need to look at ribs in a methodical way. So we talked about the L for lets, for lines. Now we're going to do B for bones. How do you approach ribs to make sure you don't miss any lesions of a rib? I used to go like this. I used to go circle like this, but that made me dizzy. So eventually, I just looked at the posterior ribs first. So this is the posterior first, the posterior second, third, fourth, fifth, sixth, seventh, eighth, ninth, 10th, 11th, and 12th. And notice that the posterior aspect of the rib goes down and out. In contrast, the anterior aspect of the rib, the right first, second, third, fourth, fifth, sixth, seventh, eighth, ninth, goes down and in. On the lateral view, sometimes people see the scapula, radiology, but you can expect to see that linear density of the scapula. You know, females and males are different from each other. Have you noticed? Their ribs are different also. Females' ribs end in a V shape. And males' ribs end in a W shape. Let's go back to the female ribs. That's because the female's costal cartilage calcifies centrally, giving a point in the middle like a spear. And the male's costal cartilage calcifies on the periphery, giving what looks like a W. So it's not usually, you're not going to see that in children, only in older people that have calcifications of their costal cartilage. Okay, this patient has 3 rib fractures. Can you see them? So I've blown up the right side, so you know you don't have to look at the left. So just on the right. And so a rib fracture is, this rib is not fractured, so the cortex is continuous above and below. Very subtle. I'm going to show you them, so you've thought about where you think they are. They are here, here, and here. Usually rib fractures occur one on top of the other. You don't usually hurt yourself and just get one fracture, usually multiple fracture. So they're usually stepwise on top of each other. Can you tell me what rib that is? It's a challenge. So in your mind, I want you to count, but I'm going to do it for you. When you're teaching and you ask a question, you're supposed to wait 5 full seconds for people to answer. But I never want you not to feel uncomfortable, so I'm always like jumping to tell you it. So I'm sorry. But I'm going to let you have a few seconds to count. So they're the posterior aspects of the ribs that are fractured. And the numbers are, this is the first, this is the second, this is the third, the fourth, the fifth, the sixth, the seventh. So the 7th is fractured, the 8th, and the 9th. So that's important that I communicate to you which ribs are fractured. This patient has 2 rib lesions that are expansile. They're hard to see. Can you see them? The more you see, the more you know. So next time, even if you can't see it now, the next time you see an expansile lesion, it'll come more clearly to you because you've seen this patient. So this patient has an expansile rib lesion. This one is expansile. Do you appreciate that? It's the lateral aspect of this rib. And this rib, the second rib here, has an expansile lesion. Patients have other problems with their chest. This is a pectus excavatum deformity. Notice how the sternum is pushed back into the chest. When we look at a pectus excavatum, the thing that we have to report is the Haller index. The Haller index is the maximum transverse dimension of the chest over the narrowest AP dimension. And if it's greater than 2.5, the patient has a pectus deformity. This pectus deformity is problematic is because it's pushing on the right atrium and limiting return of blood to the heart. So that's why we correct pectus deformities. One of the reasons we correct pectus deformities. On this gout film from a CT scan of the chest, you can see multiple nodules on the skin, right? This patient has neurofibromatosis, and they also have a pectus deformity. The reverse of a pectus excavatum is a pectus carinata, where the chest is more funnel in shape. That doesn't cause compression of the heart. We don't see it as frequently. We said lines, bones, then we look at the heart. The right atrium makes up the right heart border. It's about the same size as the hilum. The right atrium gets bigger, it gets bigger than the hilum. The right ventricle makes up the floor of the heart. As it gets bigger, it pushes the apex of the heart superiorly, giving a boot-shaped heart. In diseases like tetralogy of the lung, you see a boot-shaped heart because the right ventricle is big. The left ventricle makes up the left heart border. As it gets big, it pushes the apex of the heart down. And the left atrium, this is the carina, sits underneath the carina. As the left atrium gets bigger, it splays the carina. I'm going to show you examples of these. The right ventricle is anterior location. As it gets bigger, it grows upwards this way and obliterates this clear space behind the sternum. The left ventricle sits behind here. This is the, you see this little line right there? That's the inferior vena cava. As the left ventricle gets bigger, it bulges posteriorly. The left atrium gets bigger, bulges posterior. The mitral valve is going to be right here. So we see a calcification right here. We know it's a mitral valve calcification. So this patient has a big left atrium. So we said if you have a big left atrium, it's going to splay your carina. Here is the carina. It's greater than 90 degrees, supporting a diagnosis of a big left atrium. Up here we see a bulge. That's the bulging left atrium. So this patient has left atrial enlargement. Maybe they have mitral stenosis. This patient has a big right ventricle. What signs do we say make you have a big right ventricle? It's obliteration of this retrosternal space. So in the last patient, it was dark here, but it's white here now because the right ventricle has grown bigger and grown up right here. Also notice that the apex of the heart is elevated. Those are classic features of right ventricular enlargement. Let's go through the chambers. This patient has a big heart, right? This is obvious. Is the right atrium big? Is the right heart border tall? It is tall, right? So the right atrium is big on this patient. The right ventricle, we said, gets big when the area behind the sternum gets white. Is the right ventricle big in this patient? The left atrium gets big when the carina is splayed. Is the left atrium big? And the left ventricle gets big when the apex of the heart moves downward. So all the chambers are enlarged. What kind of disease would give you all the chambers enlarged on a chest X-ray? It could be a cardiomyopathy, but or aortic stenosis long-standing. What are these big things here then? Why are there? Does this patient have bilateral breast cancer, lung cancer, in addition to having cardiomegaly? These are the pulmonary arteries because they're in the path, right? If you're going to have a dilated left ventricle or left atrium, the pulmonary artery is going to get big, and the right ventricle and the right atrium. So long-standing aortic stenosis, for example, is going to be big bilateral masses, which are going to be the pulmonary arteries. Big heart too, right? We looked at the last patient, they have a big heart, but notice that their big heart is biggest in the middle. And this patient's big heart is biggest on the bottom. So this is a pericardial effusion, which makes sense, right? If you're going to have fluid, it's going to go to the dependent portion of the patient's heart. So with a pericardial effusion, when the heart looks big, it looks like an Erlenmeyer flask because it's bottom heavy, because the fluid is going to go to the bottom. On the lateral view, and it's not projecting so well, is this black line, a black line, and a white line. This represents fat around the pericardium, fat in the pericardium, and fluid in the pericardium. It's called the Oreo cookie sign. So it helps to diagnose a pericardial effusion. And there it is on the CAT scan. So next we said lines, bones, heart, and costophrenic angles. I think you should do the costophrenic angles separate from the lung parenchyma because it's really important to look at them and give them their full time. So the costophrenic angles, we're going to look for them to be sharp. If they are blunted on the AP view, if you're blunted at this costophrenic angle, it's 175 cc's of fluid. So you can have 100 cc's of fluid and not see it on the PA chest X-ray. And the cardiophrenic angle is important as well. This patient has a large pleural effusion, right? And look what happens to the diaphragm when you have a large pleural effusion. This is called the silhouette sign. When you put something of fluid density next to something of soft tissue density, you lose their interface. And so we don't see the right-handed diaphragm. Look at how on the lateral view, we see only one hemidiaphragm. That's because the right-handed diaphragm is being silhouetted. On the lateral view, in order to determine which diaphragm you're seeing, the left-handed diaphragm you usually only see it partway because the heart sits on top. So on the lateral view, you see two diaphragms. The one that you see part of the way over is the left, and the one that you see all the way over is the right. There's a pleural effusion on CAT scan. This patient has something that's obscuring the right cardiophrenic angle. Usually that's a notch. They had a CT scan, and it was massive lymphadenopathy and Castleman's disease. So you want to look at that cardiophrenic angle. Look at how that notch is obscured in this patient, but in this patient we can see the blood vessels going through this opacity. This was a hernia of the peritoneum up through the diaphragm, living near the right cardiophrenic angle. Other lines that we should look at on a chest X-ray are the right paratracheal stripe. This should only be 4 millimeters thick. If that gets thick, you think about dilatation of the superior vena cava or lymphadenopathy. If it's smooth, you would think it's dilated superior vena cava. If it's bumpy, then you think about adenopathy. This line that looks like a Y, you see that line? Is the anterior junction line. It represents the union of the pleura on the right and the pleura on the left anteriorly. Usually you see it more in patients that have a little bit of emphysema. There's a line going down here. It's a little bit of a subtle line, but it's called the azigoesophageal recess. It should be in the middle, and I'm going to show you a case of where it moves, and it helps us to make the right diagnosis. So in this patient, the right paratracheal stripe is thickened. Do you appreciate that? Right? There's no longer thin here. We see this big bulge. The patient got a CT scan, and it ends up being a cystic structure, which is a right bronchogenic cyst. Bronchogenic cyst, this is their second favorite location to be, so they're going to be commonly located here. Here we see the azigoesophageal recess is moving to the right. So we've got a CAT scan of this patient. And this tubular structure was causing the azigoesophageal recess to move to the right. This is a structure that starts low down on the right side of the body, and a T4 crosses midline and goes up on the left side of the body. That's the thoracic duct. It had become obstructed and infected, and that's why it moved the azigoesophageal recess to the right. We look at the mediastinum on a chest X-ray. Everything anteriorly, middle, and posterior mediastinum. Here we see a mass. We don't know if it's in the mediastinum or not, but on the lateral we can see that it's anteriorly located. When we see an anterior mass in the mediastinum, it's the 4 T's, right? It's teratoma, thymoma, T-cell lymphoma, and thyroid cancer. This one was not communicating with the thyroid gland. It was heterogeneous with an area of fat inside of it. When we see that heterogeneity, we think about teratoma. This patient has a mass in their middle mediastinum. On CT scan, it was cystic also. So a bronchogenesis, this is the favorite location of a bronchogenesis. The right paratracheal location is the second favorite location. What's wrong with this patient's chest X-ray? The hilum are too big, right? Usually the hilum should be only 16 millimeters in size. Here they are, bilateral bulky masses in the mediastinum. And what becomes your differential when you see bilateral hilar adenopathy? So tuberculosis, so something infectious. Metastatic disease to the hilum could be a differential, lymphoma, and sarcoidosis. This is sarcoidosis. And sarcoidosis has a classic look. It's supposed to look like potatoes. I don't know if you think it looks like, we talk about food a lot in radiology, but this is supposed to look like potatoes. The lymph nodes of sarcoid don't touch the heart. They stay separate from the heart. They're kind of more sturdy than lymphoma. Lymphoma is softer and touches the heart. So this lymphadenopathy is sarcoidosis. The stages of sarcoidosis are based on what you see on chest X-ray. Stage 1 being bilateral hilar and right paratracheal lymphadenopathy. Stage 2 would be adenopathy and pulmonary nodules. In stage 3, the lymphadenopathy shrinks and you just have pulmonary nodules. And stage 4, there is pulmonary fibrosis. So this is stage 1. This patient has a mass. It's located in their posterior mediastinum behind the heart. On CAT scan, this was related to the ribs and was a schwannoma. Do you see this patient's posterior mediastinal mass? You can see it behind the heart and over the ribs. But this patient's was a lung cancer, so we need a biopsy of it. You're not going to be able to necessarily say what the diagnosis is. This patient's mass is over here and over here. And when we look at this X-ray of the spine, notice the vertebrae. They're a little bit different, right? They're not perfect squares in this patient. They have indentations on bilateral end plates. It's supposed to look like the mouth of a fish, so a fish mouth deformity, and that's seen in sickle cell anemia. And so this patient has sickle cell anemia and they have a mass posteriorly located. Look at their bones, how heterogeneous the marrow is. This mass is extramedullary hematopoiesis, taking over the role for the marrow that's not working ideally. Look at the marker. Can anyone, no one ever can see the marker. Do you see an R on this film? Can anyone find the R on this film? When you see it, you're going to be like, oh, I see it. I mean, it's tilted on its side. So this is the R on the film, right? So the technologist puts that on the right side of the patient. So what's wrong with this X-ray? The technologist has hung it wrong, right? They put it into our system in the wrong direction because this is the right side of the patient. So this patient, right, has dextrocardia. This is how it should be hung, but they were willing to hang it the other way because that's how it normally looks. So you have to always have a level of suspicion about everything to make sure that it raise flags if you don't see it correctly. So this patient had a right-sided heart, but they had much more than that. In addition to their right-sided heart, they had a midline liver. And their spleens were inverted also, but there wasn't one spleen, there were multiple spleens. When you see multiple spleens and a midline liver, usually the patients have 2 left lungs. Can you imagine how things go together? So these patients have bilateral left-sidedness and polysplenia. Guess what happens to people that have asplenia, and syndrome of asplenia, what kind of lungs they have? They have 2 right-sided lungs. So it's very interesting that these syndromes should have a connection to the lung. I don't know how that happens embryologically, but so this is polysplenia, which oftentimes is associated with dextrocardia, and they have bilateral left-sidedness, which you can diagnose on the chest X-ray, but it's challenging. And if you had asplenia, it would be bilateral right-sidedness. Who do you think fares better, typically? The asplenia or the polysplenia patient? Typically the polysplenia patients. But they oftentimes have cardiac defects, which makes their life challenging as well. On the X-ray, I don't know if we can I'm going to show you later on. This patient, the bronchi are classic for left bronchi. And that's how even on a chest x-ray, if we look at the bronchi, we could make the diagnosis of bilateral left-sidedness, but I don't think anyone has ever done that. The lateral chest x-ray, there is a space behind the sternum we should look at, a space behind the trachea, or the retrotracheal space, and the retrocardiac space. The retrosternal space becomes bigger when patients have emphysema, and their diaphragms also become flatter because the lung is hyperexpanded. This is a mass in the retrotracheal space. Look at how it is deviating the trachea to the left, and this is a thyroid mass. This patient has a mass 2C behind the heart. The only thing that crosses midline on a chest x-ray is a hiatal hernia. So if you see a mass crossing midline, and if you're fortunate enough to see an air fluid level in it, then it could be nothing else but a hiatal hernia. This is the trachea on a lateral chest x-ray. This band in front is the right pulmonary artery. This band in back is the left pulmonary artery. So we can measure those, 16 millimeters and 16 millimeters, to make sure that they are not enlarged. Okay, so everything in front of the trachea is the right pulmonary hilum. Behind the trachea is the left pulmonary hilum. This patient has, your patient, they're sick, they have a fever, what would you call this? Pneumonia, right in the right upper lobe, and maybe a pleural effusion down here. So lobar pneumonia spreads from one alveoli to the other alveoli through the pores of Kahn, and it's usually very homogeneous. It usually starts peripherally. This patient has a lobar pneumonia overlying the right middle lobe. This patient has bilateral lower lobe pneumonias, and this is likely aspiration we think of. Here we see cavitation within bilateral pneumonias. We see cavitation within the staph. Here we see one mass with cavitation. They have a CT scan. We look at the thickness of the wall. If the wall is thin, less than 5 millimeters, it suggests that there's an infection. If it's greater than 15 millimeters, it suggests that it's cancer. And in between, it's uncertain. This is thick-walled and more worrisome for cancer. Do you see the consolidation in this patient? Left upper lobe consolidation. To a lesser extent, right upper lobe consolidation. Maybe there's areas of lucency in it and cavitation. So we're thinking about tuberculosis. We see that the cavitation is supported, that there's consolidation in the posterior aspect of the left upper lobe, and to a lesser extent in the right lung. This is a very good location for tuberculosis in the posterior aspect of the upper lobes. And also the patient had it in the superior aspect of their lower lobes. That's where TB likes to live. It looks like a tree in bud. Opacity, this is a tree blooming. Notice how it's kind of dotted and nodular. That's because of endobronchial spread of tuberculosis. So this is really classic for tuberculosis. Sometimes we see asbestos on chest x-ray. We might see calcified pleural plaques. You know that the calcified pleural plaques are asbestos-related pleural disease, and they usually are on the lower and posterior aspects of the pleura. This line here is called a pleural line, a subpleural line, and that means the patient has asbestosis. So this patient has asbestos-related pleural disease and asbestosis. So many more people have asbestos-related pleural disease, fewer people have asbestosis. It just means more extensive disease. It's harder to get the asbestosis.
You see the calcifications on the X-ray. It's
it's not projecting very well here, but it's supposed to look like a holly leaf. Does anyone have a holly tree anywhere? Ever seen a holly tree? It's supposed to look like a holly leaf, but I've never seen it to really look like that. You can see this when you have it on the X-ray up close, but this is hard to appreciate. Sometimes you'll see it along the diaphragm, so you'll see calcifications more frequently. Pulmonary edema we look for on a chest x-ray. The first thing that happens with pulmonary edema is that the veins going to the upper lobe become distended. Pulmonary vascular redistribution, which goes along with a pulmonary capillary wedge pressure of 15 to 18. So I look at this picture and I see that the veins are distended, and that they're bigger than the veins in the lower lobes, right? You see how they are bigger. So that's pulmonary vascular redistribution. Then the next thing that's going to happen is curly B's, some linear densities that are perpendicular to the pleura. At that level, the interlobular septa and the lung are thickened, and the wedge pressure is between 18 and 25. Eventually, fluid fills over into the alveoli, and that's a pulmonary capillary wedge pressure that's over 25. Usually that's a catastrophic event that takes that to happen, like a capillary muscle rupture or a large infarct. And usually it looks like a bat wing, and the airspace capacities are centrally located. This is atelectasis. Usually the minor fissure comes out here. Here the minor fissure has been moved up to here. So this is collapsing right at the lobe of the lung. This is an interesting picture. Which side is the sick side here? Is the left side or the right side the sick side? The left side, because it has increased density, right? This is called a veil of increased density. Notice also that the diaphragm is tented. It's being pulled up because there's atelectasis. And then this lucency right here, between the pulmonary artery and the aorta, is called the lucical sign. That represents air in the hyperaerated left lower lobe. You see on the lateral, usually the major fissure is here on the left. It's been moved to here. So all this increased density is the left upper lobe that's collapsed. Now the left upper lobe has become hyperaerated, and this is the representation of it on the frontal view, that lucency. So left upper lobe atelectasis is a veil of increased density, tenting of the hyoid diaphragm, and a lucency called a lucicle on the frontal view. Here we have left lower lobe atelectasis. Usually there's a notch between the pulmonary artery and the aorta. In this patient, it's flattened. That's called the flat waist sign. And it goes along with someone having left lower lobe atelectasis. This was a very interesting patient. On Monday morning, they came to the emergency room with chest pain. We sent them home. They came back on Wednesday with chest pain. What changed on the right side? We'll say right side of chest pain between this x-ray and that x-ray. Anyone appreciate the difference?
Less vascular.
Very good. So he said the same thing. And so that's Western mark sign. When you have peripheral oligemia, you might suspect, and I've never seen it happen before besides this patient, that the patient has a pulmonary embolism. So the patient had a CT scan, and there's a large central pulmonary embolism, which caused the Western mark sign. So that was the only time I've ever been able to diagnose pulmonary embolism on a chest x-ray. Here, this patient has, we're still looking at the lungs and pneumothorax. We want to always look for those patients in our patients with lines and tubes. You're looking at the visceral pleural line. That's one of the signs of a pneumothorax. There's no lines from the lung parenchyma going beyond that visceral pleural sign. If it's a tension pneumothorax, like in the next patient, we're going to see splaying of the ribs. We might see shifting of the mediastinum or flattening of the hemidiaphragm, which we don't see here. By the time a pneumothorax gets this big, you should have a high suspicion that it's tension and act accordingly. Because they usually don't get this big when we put lines in. They don't readily get this big. Masses are easy to miss, and every set of eyes is important. There are 6 places you should look for a mass on a chest x-ray. You should, on every chest x-ray, look behind the first right rib, the first left rib, infrahilar, retrocardiac, and behind the diaphragms. 1, 2, 3, 4, 5, 6. 46% of them are going to be here. So look there twice. So 1, 2, 3, 4, 5, 6, 1. Okay? Do you see the mass here? That there's asymmetric density behind the right first rib? And there is the mass on CT. We're going to look through a few more of these now and see if you can find the mass. I think I have to go to the back to see. Oh, I see it now. It's a 5-centimeter mass. Can you find it? It was missed for a long time because it has what's called a rising sun sign. It is this density here. So the first year, it was coming a little bit over the diaphragm. The next year, a little bit more. So it looked like annulation of the hemidiaphragm. On CT scan and biopsy, it was a benign fibrous tumor of the pleura, but still has malignant potential, so you have to remove it. 1, 2, 3, 4, 5, 6. Can you see the nodule? This one's not 5 centimeters, it's 1.5 centimeters. We're up in the ante. Here it is, right there. And on CT scan, it's here. 1, 2, 3, 4, 5, 6. 1. This one is here. On CT scan. It's spiculated and worrisome. A dominant spicule that goes to the pleura is called a pleural tail. All signs of malignancy. This patient, 1, 2, 3, 4, we just showed you this one. Showing the same one twice is not fair. 1, 2, 3, 4, 5, 6, 1. Here's the nodule here, infrahilar, corresponding to the nodule seen. This is the diaphragm next to the heart. 1, 2, 3, 4, 5, 6. This one is in location 5. Can you find it before I point to it? And there it is. 1, 2, 3, 4, 5, 6, 1. This one is in location 1. Can you see it? And there it is. This is an interesting one. There are 3 problems with this X-ray, so that gets more challenging. The nodule is in location 1. Can you see it? So this is the nodule. This is shrapnel. Usually the trachea goes down and moves a little bit to the right because of the left aortic arch. This trachea is moving a little bit to the right, to the left. So this patient has a right aortic arch. And that's how you diagnose it. That's the nodule. Right there. This patient has a subtle nodule, so I'm going to show this one. It's hard to appreciate. This patient, I mean, sometimes you need to be in the right location. Now, this is, I think it's 1 probably, right? Even if we were just guessing people, we would say 1. And here it is. There it is on this. The more you see these, the more you will be able to diagnose them on your own. This one is location 1. Do you see it? This one was a subtle one. We didn't see this for a long time. Behind the heart in location 5. This one is the technique, right? It's sometimes we get some challenging images. This one is in location 4. Can you see it? It's over here. On the lateral, it's easier to see. And then there it is. We're almost done. And this one, in location 4. And there. Last one. Location 5, do you see it? And there it is. So looking at the x-rays and the systematic lung parenchyma is important. So we did lines, bones, heart, contraphrenic angles, lungs, and now we're going to do the abdomen, and here it's important to look and notice the pneumoperitoneum, right, on a chest X-ray. If you see bilateral air under the hemidiaphragms, you think pneumoperitoneum. Be careful though if you only see air under the left hemidiaphragm, because often that's just the stomach bubble. Pneumoperitoneum usually occurs on the right or bilaterally, and usually doesn't occur isolated on the left unless you have a perforation of the posterior wall of your stomach, which is uncommon. So if you see just lucency under the left hemidiaphragm, if these weren't here, you think it's stomach bubble, bilateral pneumoperitoneum, or right side pneumoperitoneum. And again, I just want to show you the trachea. Move slightly to the left. We should look at the trachea on every x-ray, and you had seen this earlier. No, this is a new one. The trachea is moving to the left, so this is a right aortic arch. You're a great group. I want to tell you a story about this lighthouse for 1 second, if you don't mind. My family comes from Ireland. Has anyone visited Ireland? In Ireland, this lighthouse is on my mom's land in Ireland. This is the oldest lighthouse in Europe. It's called Hook Lighthouse. And there's another place called Crook. And you can see that the waters are very rough here. And many people, because it's an island, are going to make their living fishing. So there's a lot of people going out fishing in this rough water. So a lot of people die fishing in this rough water. So the salutation that the sailors say to each other, so the fishermen say to each other when they go out fishing is, I'll either meet you by hook or I'll meet you by crook, meaning I'm not going to die at sea tonight. And I use that as my rally cry for everything that we do in medicine and in radiology, by hook or by crook. If we do things to the best of our ability, these patients are going to do well. It's so nice to meet you all. I wish you every success in the work that you do. Thank you for giving me the opportunity to teach you.